and we now move ahead to the last leg of the academic deliberations before lunch. I would request Professor Khanna to kindly stay on, as he would be joining as the chairperson for this session. The upcoming session is a symposium titled 2 Decades of Coronary Stenting, a Tribute 2012. We have 3 lectures. Firstly, Dr. Ajay Sharma would be speaking on prevention of restenosis and repeated interventions, followed by Dr. Vishal Rastogi on coronary interventions and chronic total occlusion, and finally Dr. V.K. Shah on stem cell and PCI. Each of the gentlemen will have 15 minutes, and the final 10 minutes will be devoted for discussion. Without much ado, may I invite Professor N.N. Khanna, Dr. S.K. Chutani, and Dr. A.K. Gupta to kindly chair the proceedings of this session. Thank you very much, gentlemen. It's over to the chairpersons.
Now you're going to have a talk by Dr. Ajay Sharma. The biggest problem with coronary stents in the last 2 decades have been conquering 3 things. One is conquering restenosis, which has been done to a large extent by medicated stents. But the challenges which remain is how to treat a restenosis. Secondly, how do we ideally treat a bifurcation stenosis, and also how we treat chronic total occlusion. So we have 3 topics today, which would be covered by Dr. Ajay Sharma, Dr. Vishal Rastogi, and Dr. V.K. Shah. So Dr. Ajay Sharma is going to talk about prevention of restenosis and repeated interventions. Over to Dr. Ajay Sharma.
Respected chairpersons and dear colleagues, restenosis is the principal drawback of percutaneous coronary interventions. Today, in 35th year of PCI, restenosis after stent implantation remains a significant limitation. It is most commonly defined as stenosis or lumen loss of over 50% following PTCA or stent placement. It occurs in 30 to 50% patients with angioplasty, 20 to 30% patients with BMS implantation, and 5 to 10% patients with drug-eluting stent implantation. It results from remodeling and neointimal proliferation. A.R. Grundzig is regarded as father of angioplasty. He performed first human angioplasty in 1977, and after that began the era of angioplasty for the treatment of coronary artery disease. In 1986, first human stent was deployed by Sigward, and in early 1990s, bare metal stents came in vogue. They were first used, and in 1994, stress and Benny stent trials established the superiority of stent over PTCA. This slide shows the evolution of coronary angioplasty. From 1977 to 1987 was the era of PTCA, but it had its own problems like restenosis and subacute closure. Then from 1988 further on came the era of bare metal stents. They had improved rate of restenosis from 20 to 30%, but again subacute thrombosis and instant restenosis was a problem. Newer devices was also developed and investigated, including rotablator. Brachytherapy was also investigated in 90s and found to be of some success. And finally in 2002, era of drug-eluting stents began. They were thought to be ultimate angioplasty, but again they were also associated with 5 to 10% restenosis, delayed restenosis, and stent thrombosis is still a problem with them. Restenosis cascade, angioplasty leads to vascular injury to the endothelium, endothelial disruption, and also leads to mechanical stretch. After mechanical stretch, there is recoil and remodeling, giving rise to restenosis. Vascular injury leads to smooth muscle cell activation, which leads to migration of smooth muscle cells, DNA synthesis, proliferation, and growth factors are also released. Extracellular matrix formation is there, and finally it results in restenosis. So recoil and negative remodeling is an important factor in plain angioplasty causing restenosis, and neointimal hyperplasia is an important factor in instant restenosis. So what we want, we need a stent to block recoil and remodeling, and a therapeutic agent to prevent neointimal hyperplasia. So bare metal stents, they give rise to greater lumen dilatation versus percutaneous transluminal coronary angioplasty. They have lower rates of acute procedural complication and better predictability of results. No recoil or negative remodeling associated with them. And thin strut stents have been found to be more favorable as compared to thick strut stents as far as incidence of restenosis is concerned, as shown in many trials, including this one published in JACC. Classification of angiographic restenosis is given by Mehran et al., and it is divided into focal and diffuse type of restenosis. Focal restenosis is less than 10 millimeter and diffuse is more than 10 millimeter. Again, focal is divided into 4 types, including present only in articulation or gap, present only at margins, then focal in the body of the stent, and then multifocal at different sites. Diffuse instant stenosis is again divided into 3 types: intra-stent, present within the stent; proliferative, it is involving the stent and extending even beyond the stent; and total occlusion, which is the most severe form of the restenosis. So focal restenosis was found to be 42% in one study, and it was the commonest one, and total occlusion was found to be 6%. It was the least common one. Instant restenosis is mainly caused by intimal hyperplasia, as shown in this slide. So because restenosis was again a problem even with stents, so various drugs were tested, oral drugs were tested to prevent restenosis. Out of these drugs, Trapidil is one. It is a phosphodiesterase inhibitor and a potent antagonist of platelet-derived growth factor and of thromboxane synthetase. It inhibits myointimal proliferation, and it was found to be beneficial with balloon angioplasty only, not with the stents. So it is not that useful. Recently, another oral drug, Bindarit, which is an anti-inflammatory drug which reduces neointimal formation by reducing smooth muscle cell proliferation, has been tested, and its oral administration has been shown to reduce restenosis following BS implantation at 6 months in a phase 2 pilot trial, and still it needs further investigation. Cilostazole, pioglitazone and sirolimus systemic administration has also been tested but was not of much use. But local administration of sirolimus and paclitaxel was demonstrated to be very useful in preventing restenosis. Based on this concept, drug-eluting stents were developed. There was advent of drug-eluting stents in 2002 and 2003. It was a vital breakthrough in the field of PCI. Cypher stent, which is a sirolimus eluting stent, was developed in 2002 and brought to market in 2002-03. And Texas stent, which is a paclitaxel eluting stent, was developed in 2003. They were the first generation drug-eluting stents. And after that, Yukon Choice came in 2003, and then second generation stents, Zoterolimus eluting Endeavor stent and Everolimus eluting Zyme were introduced in 2007, 2008. They have thinner struts, and then came the concept of bioabsorbable polymer and biometrics, which elutes Biolimus and Supralimus, and Biomime were introduced in 2008 to 2010. And recently, Promise Element Stent, Resolute Integrity, Synergy, they have been introduced, and they are they are more deliverable, and research is going on to find an ideal stent. For example, a Mitsu stent is being developed, which is based on nanotechnology with strut thickness of 40. Trials have begun. It is Merilimus eluting with no polymer. It's in fact a 4th generation stent. And new research has been undertaken in the field of stent technology, and completely bioabsorbable stents have been developed, and leader among them is bioabsorbable vascular scaffold, or BVS, which is PLLA based. It is about to be introduced in the world market soon. So this slide again shows different classes of stents: first generation, first generation Cypher and Texas, second generation Endeavor and Zyme, and third generation being represented by Biomime. As all of us know, in diabetes there are higher incidence of restenosis. So it has been extensively studied with various drug-eluting stents. Both sirolimus and paclitaxel-eluting stents, they have substantially reduced angiographic and clinical restenosis, but they have not eliminated the excess risk of restenosis in diabetics compared with non-diabetics. Edge effects appear to be more severe in diabetes mellitus patients, and there is greater emphasis on stenting normal to normal vessel. Everolimus and Dr.R.M.L.Hospital eluting stents have been found to be most effective in diabetes mellitus in preventing restenosis. In DES, restenosis, where various factors which are important include among patient factors, female gender, diabetes mellitus, chronic renal failure on hemodialysis, prior MI, prior PCI. Among vessel factors, important ones include chronic occlusion, instant restenosis, bifurcation lesions, lesion location in left anterior descending artery, small vessel less than 2.75 millimeter, long lesion length more than 20 millimeters, severe calcification or tortuosity. Procedure-related factors include smaller post-stent, minimal lumen diameter, stent under expansion, over-dilatation of an undersized stent, stent fracture, and non-uniform stent expansion, which leads to altered drug deposition. This slide shows DEX fracture during deployment of the stent, which later on caused restenosis. This slide shows stent under expansion, which later on leads to stent restenosis during follow-up. So important technical factors in inducing restenosis and TLR when two stents are implanted in bifurcation include high pressure side branch inflation, two-step case, use of low compliant balloons, less protrusion of side branch into main branch, that is mini crush, and IVUS guided stenting as far as possible. Brachytherapy was also extensively studied for prevention of restenosis, but it has its own problems. Beta and gamma radiations were found to be effective in preventing restenosis, but late restenosis is common because of edge effects, and late thrombotic occlusion is known to occur, and the equipment is quite cumbersome and very costly and not easily available. Research has been done in the gene therapy also for preventing restenosis. Gene-eluting stents have been investigated. Gene-eluting stents of plasmid DNA encoding VEGF2 have been investigated in animal models and found to be effective, and further research is required in this field. Implantation of a drug-eluting stent with a different drug, that is switch strategy in patients with drug-eluting stent having restenosis, has been found to be more effective than using plain BMS or balloons or same stents, as found in RIBS-3 trial recently. Drug-eluting balloons have been recently introduced. They are emerging technology under evaluation. Paclitaxel-eluting balloons are used because of their rapid uptake of paclitaxel and good binding. Sequent please from B-Bron, Inpec from Medtronic, Dior and Pecocath balloons are commercially available. It's a viable option in instant restenosis, small arteries, and for side branch lesion in bifurcation stenosis, and have been approved by FDA for management of instant restenosis. There is no need for dual integrated therapy. Absence of polymer is there, so no risk of SAT is there. Drawback is 30% crossover to stenting. In one study, it was shown that drug-eluting balloons are very effective in preventing restenosis, which was published recently. So bioresorbable stents have been developed. There are exciting invention in the field of stents. Igaki, Tamai, BVS, Reva, BIT and Biotronic, they are some of the stents which are being developed or have been developed. Out of these, bioabsorbable vascular scaffold, also known as BVS, which is PLLA based, which is completely bioabsorbable within few months, has been extensively tested and is about to be launched in the market soon. So when you are going to perform PCI to prevent restenosis, think twice, especially in multivessel disease. Use drug-eluting stents. Use a GP2B3A inhibitor or possibly pivaridine, plus use a high-dose clopidogrel or prasugrel or ticagrelor, and maximize secondary coronary prevention even in the short term, which is very important in prevention of restenosis in the form of optimal glycemic control, aggressive lipid lowering, that is LDL up to less than 70, and ACE inhibition. what can patients do to protect themselves, or what you should advise to patients, that is heart healthy lifestyle, a diet low in fat, rich in fruits and vegetables, regular exercise, weight management, blood pressure and diabetes control, cessation of smoking, minimal or no alcohol consumption, stress management in the form of regular meditation, regular following up with a cardiologist and taking medications as prescribed. So to summarize finally, restenosis is still an Achilles heel of PCI, and its prevention is the most challenging aspect of coronary intervention. Vascular brachytherapy has been found to be effective, but its cost and availability are deterrent, along with issues of late thrombosis and late restenosis. Drug-eluting stents have provided new dimension by effectively reducing restenosis in de novo lesions and recurrent restenosis to 5 to 10%. Newer technologies are continuously improving upon drug-eluting stents. A breakthrough technology is sorely needed to treat this malady or prevent its occurrence altogether. Biological friendly stents, drug-eluting balloons and biovascular scaffolds may improve the outcome. Lifestyle modification to adopt a heart healthy lifestyle, effective control of blood pressure and diabetes, meditation and regular treatment are very important in prevention of restenosis. Thank you.
Thank you, Dr. Sharma. That was a very good talk. We covered almost all the aspects. But the only thing what we need to emphasize is that technically a good, very well deployed stent actually leads to a very little restenosis. The most important thing is that you need to overdilate, you need to do an avers and make sure that stent is properly sized and properly dilated. We should not only go by the vessel size on an angiogram, but it should be post-stenting, we should always, and it may be pre-stenting, we should always do an avers and see whether the stent is adequately sized and uniformly expanded, and there are no edge dissections. Now, if there are any questions, we can take it right now, or we can ask